Hello, this is David Anthony, and I'm here to introduce you to our talk, which we are calling Coaching for the Development of Master Adaptive Learners. And our subtitle today is A Workshop Turned Video, because this was originally planned to be a full-on workshop with breakout groups and chances to practice with role play. But we have tried to condense it down into a 30-minute video, and are hopeful that we've captured the essence of what we wanted to get across to you. And who we are is the four of us: David Anthony, Jason Chao, Sherilyn Smith, and Leslie Fall. Jason and I are both family physicians and clerkship directors in family medicine, and we both serve on the editorial board of the Aquifer Family Medicine cases. Sherilyn Smith and Leslie Fall are both pediatricians, and they both serve in the leadership of Aquifer. Sherilyn Smith is the chief academic officer, and Leslie Fall is the chief executive officer of Aquifer. We do have a brief disclosure, which is that Aquifer is a federally recognized nonprofit health professionals education organization and is an SCFM conference partner. Doctors Fall and Smith both receive salary support for their roles with Aquifer, and Doctors Chao and I both receive honoraria for our work on the editorial boards. We have no financial interest to disclose or other commercial interest to disclose. And so just a brief outline, we are going to start with an introduction to the Master Adaptive Learner framework from Jason Chao, and that's going to lead us into a discussion of the development of tools for formative assessment for the development of what we call cognitive competence, and that's going to be by Leslie Fall. And then that will lead us directly into Sherilyn Smith, who's going to talk about coaching skills for the Master Adaptive Learner using those formative assessment tools that we've presented before. And then finally, a brief demonstration by me in place of a role play. And so let's dive in with Jason Chao with the Master Adaptive Learner framework.
Hi, I'm Jason Chao. I will start this presentation by exploring the concept of the Master Adaptive Learner. This comes from work by the AMA's Accelerating Change in Medical Education Consortium. I wish to recognize Bilku Chair, who served on the consortium and allowed us to borrow some of his slides. All of the ideas that I will talk about over the next few slides come from a strong literature base in the medical education and general medical education literature. We know that medicine is more than just knowing a collection of facts. Students need to be able to integrate the information that they have acquired and apply that knowledge to a unique patient to develop a diagnostic and therapeutic plan. They must learn to make good decisions and act on them. This is a definition of a Master Adaptive Learner by the AMA Consortium. A Master Adaptive Learner is an individual who utilizes the metacognitive approach to self-regulated learning that leads to adaptive expertise development. The individual in our context is a medical student, but can also be a resident, fellow, or faculty member. At its core, adaptive expertise is a couple of things. It is the ability to demonstrate routine expertise, taking a known solution and applying it to an identified or known problem. You have to be able to do that effectively and efficiently as a master clinician over and over. But you also have to be able to recognize when there's something different about a particular situation where the routine approach won't work. When faced with this new or novel challenge, adaptive expertise comes in. It is the ability to take what you know and either solve the new problem you've never faced before using that old information, or to incorporate new learning and develop a new solution. The Master Adaptive Learning model has 4 phases: planning, learning, assessing, and adjusting. Those of you that do quality improvement work will recognize that this looks a lot like the PDSA cycle that we use for quality improvement: plan, do, study, act. What better metaphor for ourselves as practitioners and our trainees than to think about doing PDSA cycles on ourselves as learners? Now I'm going to expand a little bit about each of these phases. We want to move inside the mind of the learner. Planning contains 3 identifiable steps. 1, identifying a gap in knowledge, skill, or attitude. 2, selecting an opportunity for training or closing that gap. 3, searching for resources for learning. In planning, there are a few skills that are really important to develop within our trainees. The literature around adaptive expertise talks about a series of skills that can be practiced and developed and eventually become a habit of mind. In the course of a day in practice, I can end up identifying a number of gaps in my own practice. Often I do not have time to look up everything right away and need to be selective. Many trainees skip this planning phase. If they've got a few minutes, they are going to just dive right into the learning without stopping to think about planning. One of the other things that is important to think about for this planning phase is gap identification. There's a lot of different things that can trigger that gap identification. It could be that moment of surprise that just caught you off guard, like, I don't understand why that happened. Or an outcome for a patient that didn't go quite as expected. Or, ooh, I'm feeling a little bit anxious right now. We should encourage our students to use that sense of emotion you feel but might not understand to dive a little deeper. Use that as a cue that I need to understand why I'm feeling a little bit anxious right now. Oftentimes, this is because there's a gap we're starting to identify. As a preceptor, you may have to explicitly identify a gap for a student. Another good source of identifying gaps is assessment data. Really good self-assessment or external assessment data can help highlight areas of strength, but also areas of gap. Question banks are another useful tool for this. And asking the right question is important. Think about your students who are able to really ask insightful, thoughtful questions to trigger further learning. Next is the learning phase. This is a mixture of critically appraising new resources, which is really important, but then using effective learning strategies to actually do that learning. When I was in training, techniques such as reading and then rereading, highlighting or underlining, and cramming were the most commonly used. Those have all been shown over and over in the education literature to not be effective strategies. We should be encouraging effective, proven strategies such as spaced repetition learning. One example is flashcards. Or retrieval practice, which leads us to the next phase, the assessing phase. This is really where the individual is able to try out what they've learned. Within this assessment phase, there are two important aspects. One is informed self-assessment. This can be greatly improved when paired with external feedback. This is when teachers or practice questions can be very useful. The value of a really good assessment tool is that it can highlight some of the gaps in knowledge that can flip the learner from the assessing phase back into the planning phase. The learner has either identified a new gap or the solution they thought they had wasn't actually working, so they need to start all over again. The adjusting phase. The literature would say that we practicing physicians don't do this very well. We often don't actually incorporate new learning into our practice in a way that changes our care for our patients. We also need to think about how big is the change. Does it need to be applied to just myself as an individual practitioner or throughout the entire system I work in? Clearly, systems change is harder to implement, but more effective. Now I'd like to pull back from what's going on inside the mind of the individual and look at the working learning environment for the learner. Students get exposed to comments and situations I never want them to see, such as a resident making fun of a patient. This is the hidden curriculum. So it's actually really important to know that the environment is impacting their ability to learn. And if you add on top of that things like trying to perform for grades, letters of recommendation, or competition, there's a lot going on that can actually slow down or completely impede the learning that we want them to have. Finally, I'd like to highlight the batteries. These are internal features that power this type of learning for students. They are all very important. As you think about your trainees that you love working with, my guess is that they demonstrate most of these characteristics, and the learning that they do is mainly because of the power from these batteries. Now I'd like to turn it over to Dr. Fall to talk about cognitive competence.
Thank you, Jason. Typically, when we think of master adaptive learning in medical education, a scene much like this one comes to mind, with an experienced clinical preceptor working with a medical student to develop and advance his or her patient-focused clinical skills. I'm sure we all agree that advancing our learners' performance in these observable clinical competencies is the ultimate goal of our coaching activities. However, underlying these important clinical skills is a great deal of knowledge and information management, clinical reasoning, clinical decision-making, and well-calibrated clinical judgment. Thus, we must recognize that excellence in the clinical competence we observe, assess, and coach must be built upon a robust foundation of cognitive competence, which is much more than simply the, quote, medical knowledge competency most frequently included in the standard ACGME and other competency frameworks. The challenge in coaching toward the development of cognitive competence in master adaptive learners, however, is that, just as Jason identified, it lies hidden within the mind of the learner and we can't exactly unzip their brains in order to look inside and assess what is going on. And further, the assessments that we do have provide little to assist either our learners or us as faculty to effectively coach for cognitive competence. As this is fundamentally a formative journey, our goal in coaching is to help learners help themselves, rather than to synthesize and interpret the data for them, the method by which most of our current assessments depend. What we need is a new type of data designed primarily to inform the learner and useful for every step of their master adaptive learning cycle. It is interesting to note that our learners already recognize this, evidenced by the plethora of study question books and software so popular among them today. Unfortunately, the nature of standard multiple choice questions only provides learners with dichotomous feedback in the form of correct or incorrect answers, which is not sufficiently nuanced for the development of true clinical cognitive competence. In order to structure a framework for how cognitive competency development might progress, I have found it useful to consider Bloom's taxonomy for learning objective development. At the base of any new learning are the important cognitive skills of gaining, remembering, and understanding new knowledge. This is followed by the ability to retrieve and apply knowledge for the purpose of problem solving through analyzing, evaluation, and then creating a plan, and finally deciding on a safe and effective course of action. Additionally, it is important to recognize that the ability to effectively rise through Bloom's taxonomy is context-specific. For example, as a pediatrician, I am quite cognitively competent in the management of chest pain in children. However, put me on the adult cardiac unit today, and I would be at a loss to provide competent patient care. To validate this approach, think for a moment about the development of your own clinical cognitive competence and how the accuracy of your relevant knowledge base, the speed of your appropriate knowledge retrieval, speed of your problem solving, and finally the calibrated certainty of your own decision-making and clinical actions has developed and advanced over the years, and how these have been honed and refined repeatedly through experience in your context-specific domain of practice. Think too about your best teachers and coaches, and how strongly they have influenced the development not only of your clinical skills, but also the methods they have employed to help you hone your clinical mind as well. What we are coaching to achieve is known as adaptive expertise, the ability to recall what you know, to apply that knowledge to a new or ambiguous patient problem, and to advance and hone your knowledge base in the process. Importantly, these higher order thinking skills are not necessarily the same as those assessed in good test takers. Developing real adaptive expertise is hard work, and it does slow all of us down at first, which can be very frustrating to a novice learner who sees progress solely through a lens of speed. And thus, much as we teach and assess clinical skills through practice, observation, data collection, feedback, and repeat practice, we must do the same for cognitive skills. We must provide a simulated yet authentic cognitive experience and an opportunity for safe learning through error, practice, and adjustment in progressively more difficult or risky environments. What we need is essentially a cognitive sim center and a similarly developmental framework for assessing cognitive competency. The details of our proposed model are in your handout for consideration at your convenience. So, with that as background, how might we reform our current summative knowledge assessments to promote and support the development and coaching for clinical cognitive competence? The work begins at the question item level, which can be seen much like a single decision for a given patient. In this manner, a 50-item assessment can be considered observation of 50 different patient care clinical assessments, decisions, and proposed actions. As you can see here in our new formative assessment platform, the transformation to a cognitive sim center begins with the requirement that the learner assess his or her level of certainty for each decision or answer. As I have previously mentioned, this one change and the provision of this data to the student provides ample information to begin the master adaptive learner cycle for cognitive skills. Once again, we have provided this sample student report in your handout. In this manner, for each of the family medicine learning objectives assessed in the exam, the student is provided context-specific feedback about his or her level of cognitive competence. Across the assessments, a comprehensive curricular sample is collected and provided over 2 points in time during the clerkship, early and late, providing the learner with previously unavailable clerkship-specific formative data needed to assess his or her overall cognitive strengths and weaknesses at each point in time. These data enable the learner's ability to plan, learn, reassess, and readjust his or her knowledge base, clinical problem solving, and decision making between now and the next assessment. Learners are able to sort the data across a variety of domains, giving them the tools to transform the feedback into targeted goals for practice, both clinically and online. Early in the course of a clerkship, when a learner's relative lack of knowledge and experience is expected, warnings should only be communicated when a learner's overall knowledge base and cognitive competency is very low and/or quite miscalibrated compared to peers. Otherwise, a fair amount of knowing that you don't know is acceptable, and the range of learners that are, quote, just fine at this stage is wide. This stage provides a perfect opportunity for a master adaptive learner to assess, problem solve, set learning goals, and plan his or her learning activities using the information received in the assessment report. This stage also provides a great opportunity for learners to work with clinical coaches, leveraging a coach's experience to identify targeted learning opportunities or to dig deeper for better insights into the root cause of current challenges. Over the course of training, as performance expectations rise, the impact of progressive formative assessment becomes more apparent. Armed with a more robust toolbox of data, a master adaptive learner now has what he or she needs to take a more active role in planning and executing a thoughtful learning journey, leveraging the use of coaching when needed, and in the end, experiencing a much deeper sense of empowerment over his or her achievements. Thank you for your time and listening today. I'll turn it over now to my colleague Sherilyn Smith to dive a bit deeper into the clinical coach's toolbox.
Thank you, Jason and Leslie. That was so great. What a great overview of the Master Adaptive Learning Framework and cognitive competency. And I'm Sherilyn Smith, and I'm a pediatrician, and I'm going to talk to you a little bit about what is coaching and some coaching techniques to put this all together. And as Jason and Leslie were talking, it really reminded me of a student that I'm working with who's been on a leave of absence and is working on his clinical skills. And he was working through his standardized patient, and we were reflecting together, and he said that he was having a really hard time remembering the questions to ask from the review of systems to really flesh out the associated symptoms and the pertinent negatives. And he asked me, what would I do? How do I do it? What's the best way to do things? And I stopped and said, well, what are some ideas that you have? What are some things that you'd like to try? And he came up with 3 or 4 different strategies, and his energy around that conversation was so positive. And I think it's because he realized that he already had the tools, and he knows how he learns, and he's the one that's going to actually ensure his success. So I'd like to talk a little bit more about the difference between being a coach, an advisor, and a mentor. And as you can see in the slide, one of the most important things is who's the expert in that conversation. So when people come to us for mentoring, they view us as experts. We've walked the path that they want to walk or something similar, and so they're really looking for that guidance and experience that we've had that will inform where they go. An advisor has lots of information, and we may actually be an expert in some part of this, but the people that we're advising may have to apply it a little bit more, and they may end up in a different spot than we are. And finally, as a coach, it's really the learner who's the expert, just like the students that I'm working with. They know themselves, all of their context, and really understand, hopefully, what they're working toward. And it's your job as a coach to help them uncover that and help them be clear. Similar to who's the expert, it's who sets the agenda. And in coaching, it's really the learner you're working with who sets the agenda, focuses it, and then really can identify what success looks like. And finally, a real-time tip to figure out if you're in that coaching space or doing something else, it's who's doing the talking. And in a coaching relationship, it's really the person you're coaching that should be doing most of the talking. Your job is to ask some questions to help clarify and maybe reframe. But if you're doing a lot of talking, that probably means you're advising or mentoring. So I want to share just a really important fundamental that I hope you can take with you, and it's about your coaching mindset. So really trying to stay curious about what is going on with the person you're coaching as opposed to diagnosing what their problem is. Exploring possibilities opposed to going in and fixing it for them. And I think that that's the hardest thing to do from a physician standpoint, is we're really trained to be fixers in addition to helpers. Really remaining open to possibilities and as opposed to prematurely focusing on just one idea, especially if it's the idea that you came up with or resonates with what you were thinking. Empowering the person you're coaching to solve their own problems as opposed to managing their process. And finally, and maybe one of the most important things, is helping the person develop as a person, as a clinician, as a learner, versus really focusing on their performance only. So I want to share a tool to keep you in the coaching space. And I think that this is really powerful, and I hope that you can employ it. And it's really asking great and simple questions. So some of my favorites are asking what's on your mind or what you would like to focus on. And then the real magic is then to say, and what else? And keep asking, and what else, until they don't give you anything new. And that's just like clarifying agendas with patients when you're in the room with them, when probably there's too much to talk about. And once you've really got them to say, and this is what I'd like to focus on, then follow up with this magic question, what's the real challenge here for you? If they're silent, you have success. If they say, that's a great question, you have success. Make sure that you just ask one question at a time and wait and listen and create that space for reflection and trust. So I'd like to loop back around and talk a little bit about the goals for the coach as it relates to the Master Adaptive Learner model. And so you can see in the learning, assessing, and adjusting phase, fostering reflection is super important, and you can do that with questions. If your student is in the planning phase, really help them set goals. Maintain that student locus of control, don't guide the agenda too much, and then help them balance that performance versus developing as a person. In the learning phase, support experimentation. In the assessing phase, really talk about and plan for how they're going to use the data that they're going to get, both the quality and assess the quality and quantity. And finally, in the adjusting phase, really support them and their resilience and normalize things for them, because this cycle is a cycle and they're always going to be adjusting. And maybe share that you've done that too. So let's put it all together, and we'll do that in the next short video about coaching for Master Adaptive Learning. And so you're going to see this in action. But before you see that, we invite you to pause and reflect on how you might use this approach with your learners. What really sticks for you? If you have somebody there, practice. That would be great. But just spend a moment before you jump in and see this great video.
Thank you, Sherilyn. And this is Dave Anthony again to give you the brief demonstration. And I would encourage you, when this is over, to stop and pause and consider, if you have someone with you, to actually go through and do the role play yourself. The materials needed to do so are available with this presentation. And so the scenario is that it is midway through the family medicine clerkship, and all the students have completed the first round of the Aquifer formative assessment at the beginning of week 2, and we're meeting with students one by one. And I'm meeting with Linda, who's completed surgery prior to her family medicine rotation, but nothing else. And she's very interested in family medicine, but is concerned that she got a red flag in her formative assessment. And I know that the red flag of the report indicates that Linda had a mismatch between her level of certainty and her knowledge base. And I also know that Linda has had the opportunity to review her item-by-item performance, and she can see where the strengths and weaknesses lie in her cognitive competence. And this shows graphically where Linda lies, where there's a difference between her speed and certainty and her level of accuracy. And this is the report that the faculty member gets, indicating that despite the fact that Linda was able to retrieve her knowledge easily and with a high degree of certainty, she did not perform accurately on the assessment. So hey Linda, how you doing?
I'm doing well.
I wanted to check in. I know it's midway through the rotation, and have you had a chance to look at your report?
I I did, and I'm a little bit concerned about the report.
Yeah, tell me more about that. What concerns you?
Um, so in terms of like the results, it says here that my understanding of family medicine is lower than expected at the start of the rotation. And I'm just worried that I'm not where I'm supposed to be.
Yeah. And anything else? What else did you think from that report?
Um, Let me see here. So it says that my overall knowledge base has many gaps, and you will need to focus consistently on developing a foundation.
Yeah.
And I do have like a list of certain areas to focus on. I guess so, like a list of the questions I had gotten wrong.
Okay. Yeah. Tell me more about. Have you had a chance to see if there's any patterns there? Because I don't have that. That's for you. I don't have that information. But tell me what you've seen.
So it seems like a lot of questions I am uncertain about. And then consistently, it seems like preventative care, health maintenance, along with OB questions are the ones I seem to struggle with.
Okay. Okay. And does that? So I forget what rotations have you done so far. Like, have you done either OB or general internal medicine, where you might have done some of those things before?
No, so I started on surgery, and then
Okay.
this is my second rotation.
Okay. Okay. So those might be areas where you haven't had as much exposure. Yeah. Anything else that strike you about the report, or things you feel like you want to have as goals now for the rest of the rotation?
I'm not really sure. I feel like this is really like broad. Like my knowledge base is not that good, and I'm not really sure how to like focus my efforts into building that.
Yeah. Well, it's early in the rotation, so one of the things, when students it's not surprising you're getting some of the questions wrong, and it's also early in the year, right? So you haven't done OB and some of those things, and when you're uncertain, when you get something wrong, and you feel like you're uncertain, then that pairs up nicely. That means you've got some learning to do. It just means you have to do some studying and have some more clinical experience. And so I'm wondering if you can, um, what your study strategy will be, and what sort of worked for you in the past, and what do you plan to do for the remainder of your rotation here?
Hmm. Yes.
I think that's a great strategy. It's a good goal. It's a achievable amount on a given evening, and then in a couple more weeks you'll do another one of these assessments again, so you'll get a sense of how you're progressing. So any other thoughts and things I can do to help you now?
Um, I don't think so. I think you answered my question. I wanted to ask if there was another check-in point
Yeah.
before the end of the rotation.
Well, we'll do this one. We'll have you do one of these learning modules again, one of these assessments in a couple of weeks. And so your goal is to prepare. One of your goals should be to prepare for that, to keep moving towards the end of the rotation. And we'll get a check in to sort of see how you're progressing. And I imagine you will move forward. Most students tend to over the course of the rotation, but it gives you a sense you've got a little bit of work to do. But please come to me if there's things that are getting in the way of you studying, and things I can do to help. Okay.
Okay, that sounds great.
All right.
Really helpful. I appreciate the check-in.
Great. I'm glad it was helpful, and I look forward to seeing how you do and how you progress. All right. Thanks, Linda. So thank you so much for attending this video. We hope this was helpful, even though it couldn't be a full workshop. We would really love to get your feedback on these formative assessment tools and on the coaching tools that we've developed. And we invite you to respond to a brief survey which you can access by pointing your camera at that QR code on the screen. We look forward to hearing from you.